Yeah, thank you very much, dear Chair. Thank you very much for that nice and kind introduction. Dear ladies and gentlemen, within the last 4 years, integrated PET MR scanners have been successfully introduced into clinical imaging. And so in the next 20 minutes, I would like to give you some potential applications of this new emerging imaging technique. So I think, yeah, perfect. So first I would like to give you some reasons why we should perform simultaneous PET MR imaging. Then I would like to give you some, or name some potential applications which might be highly benefit using PET MR in the future. So first, why simultaneous PET MR? And so we know that, PET-CT has been well established as a powerful whole body staging tool in oncological imaging, but now we have the next player, PET MR. PET MR has been successfully introduced, combining PET, which provides functional and or metabolic parameters, which enable a highly valuable evaluation of tumors or certain other pathologic conditions. Then we have the MR component providing morphological imaging, and that's new, that we can also perform or contain function parameters. So that enables a marked extension of the diagnostic spectrum. And after image fusion, both modalities provide complementary information which can be used for image interpretation. So we know that PET-CT is considered the hybrid imaging modality of choice. But now we have the MR component, which enables a marked or much better, excellent, and superior soft tissue contrast. MR provides a number of certain different, highly specific MR sequences for certain issues, including functional imaging. Then PET MR may enable a marked reduction of the radiation exposure for the patient, and now we can perform simultaneous imaging since PET-CT is performed subsequently. First, the CT scan, then the PET scan. So many studies focused on a retrospective fusion within the last decade. First PET-CT, then MR. They fused the images, but that method has some drawbacks. On the one hand, you need special fusion software for the image fusion. That is time-consuming. On the one hand, the data acquisition as well as the fusion process as well as the data analysis. Then there might be the occurrence of misregistration artifacts, so it's quite hard to get an equivalent co-registration of the PET and MR data sets, as well as potential artifacts by patient movement. So in PET-CT, patients are better with the arms up, and PET MR with the arms down, besides the body, as well as organ movements, so bowel movements or bladder filling between these two examinations. And then PET data are acquired with PET-CT, which means increasing radiation exposure. So Siemens was the first company which enabled the introduction of that PET detector within the MR gantry. And that now enables the simultaneous data acquisition of PET and MR. Enables a much better co-registration of these two imaging data sets within reduction of the radiation exposure, but there are still minor limitations due to the MR-based attenuation correction and the SUV quantification. So in essence, we performed more than 2,600 PET MR scans already, and more than 90% are based on oncological purposes. And so you can see here on that pie chart, PET-CT is a whole body staging tool. We perform more than 90 or 99% whole body imaging, but in PET MR, only less than 40% are performed whole body, more than 60% are partial volume scans, which means we are focusing more on a specific region, a specific organ, which has to be evaluated. And so this slide or the table should give you an insight which tracer which we're using. And so in the vast majority we use FDG. More than 2/3 of our scans are used with FDG. Less frequently DOTA-TOC for the evaluation of neuroendocrine tumors, PSMA or choline, but especially PSMA for prostate cancer is highly sensitive for the detection of prostate cancer or metastases, and the other ones are used less frequently. So initially, the majority of our clinical trials were performed in a 2-examination workflow. So first, patients were injected with a tracer, after 1 hour PET-CT, after another hour the PET MR scan. But now there's a shift within the last 2 years that we also apply the PET-MR increasingly for an exclusive PET-MR scan, but only for specific indications. I will show you some later on. So now let me show you some potential applications of this new technique. And this slide should show the main fields we're using PET-MR for. In the vast majority, we use it for oncological purposes, but also for cardiovascular imaging, for the evaluation of inflammatory diseases, and also we start with neuroradiology, not only for brain tumors, also for the evaluation of neurodegenerative diseases. But let's start with oncological imaging, and there I would like to show you a case about a 57-year-old patient. She had a diagnosis of primary cervical cancer, was treated with radiochemotherapy and pelvic and para-aortic lymphadenectomy. Now she comes back, has pain in her back, and she lost weight. So she is highly suspicious for a tumor recurrence. We performed the PET-CT and PET-MR examination, and as you can see, she has lymph node metastases in the para-aortic region, as well as bone metastasis in the lumbar spine and the left proximal humerus. But when you compare those images, you can see the image quality and the detectability between these two techniques is almost the same. And so this was the results of certain initial studies comparing the staging performance between PET-CT and PET-MRI. They reported more or less comparable results for whole body tumor staging. There were some advantages using PET-MRI, which enabled a higher diagnostic confidence for the differentiation or evaluation of benign or malignant lesions. However, then we had to figure out which might be potential advantages using PET-MRI over a PET-CT or potentially besides PET-CT. On the one hand, it's clear with the MR we have an excellent and superior soft tissue contrast, which I've mentioned before. But then we can also obtain many different parameters in terms of multi-parametric imaging. And with the omission of the CT component, we can enable a marked reduction in the radiation exposure for the patient. So let's start with the soft tissue contrast. There might be certain areas of the human body or organs, MR is definitely better. For example, liver imaging, evaluation of the female pelvis or male pelvis for brain tumors, etc. And so here I would like to start with an imaging example of a staging examination. It's a cancer patient and there's a small hypodense lesion in the CT scan, no tracer uptake in the PET, but it does not have to show tracer uptake since it's a small lesion, and lesions which are smaller than 1 centimeter, especially smaller than 5 millimeters, do not show a tracer uptake. So we are not sure, is it the metastasis, is it a benign lesion? We are not sure. And then that's the value of using PET-MRI. In this examination before the PET-MRI exam, you can see a hyper-intense signal in T2-weighted imaging, also no tracer uptake, since this is too small, and also a high signal on the ADC map, the corresponding ADC map, so we can give the patient a final diagnosis. It's not a metastasis, it's a liver cyst. And with PET-CT, we would invite the patient probably for another follow-up examination or would induce an MRI. Another example, quite the same situation. Hypodense liver lesion without the right liver lobe. We are not sure metastasis or probably an hemangioma or liver cyst. With PET-MR, still no trace uptake as well. Hyperintense lesion, potentially suspicious, but with the additional information provided with MRI, you can see there's a hyperintense lesion in diffusion-weighted imaging with a single drop in the ADC map. And so based on the additional information by MR, they could be identified as a metastasis. And so Dr. Weidewan from our department, he evaluated and compared the staging performance of PET-CT and PET-MRI for the evaluation of liver lesions. And he could show that PET-MRI showed a significantly higher sensitivity and also a significantly higher values for diagnostic accuracy in the evaluation of liver metastases or detection of liver metastases. And with PET-MRI, 10 additional liver metastases in this patient cohort could be identified in comparison to PET-CT. So another region which I'm more focusing on in my scientific trials are the female or male pelvic regions. And so we evaluated the diagnostic performance of PET-MRI for the evaluation of primary cervical cancer. In the study which we published this year, we could show that integrated PET MRI has a high value and could perform very, very well for primary staging of cervical cancer patients. On the one hand, you have the MR component, which is the modality of choice for the evaluation of the local tumor and for potential infiltration of the adjacent anatomical structures. Then you have the PET component, which is known as a whole body, highly accurate staging tool. Now with PET MRI, you can combine those two imaging techniques, and you can perform highly accurate local tumor staging and whole body tumor staging. And therefore, it has the potential probably to function as a one-stop shop imaging tool for those cancer patients, but which has definitely to be evaluated in further studies. So the question was, since more than 90% we use it for oncological purpose, can we use it also for different other indications? And the answer is sure. I've shown before, yes. So this is an example of a patient with an acute myocardial infarction of the lateral wall. There you can see there's an area of the myocardium with a reduced tracer uptake, which indicates non-viable muscle cells. So these cells are dead based on the infarction. But that area nicely matches with the late enhancement here on the LGE image, with the area of an hypermotility in the CNS sequence, and also there's a correlate which nicely matches in the perfusion-weighted imaging. So using the PET data provides an additional information about the viability of the myocardium and can differentiate between viable and non-viable parts of the myocard. So another example from a study from one of our colleagues, he evaluates or he runs the trial about PET MR enterography. And so these are images from a study evaluating inflammatory bowel diseases. So it's a 72-year-old male patient with a Crohn's disease. There you can see there's a wall thickening, conscious enhancement of that bowel segment. And then for those patients, it's highly, highly essential to differentiate, is it more a stricture, then you would undergo surgery, or potentially an inflammatory process going on. So when we switch the lights on, you can see there's a focal tracer uptake of exactly that bowel segment. And so we can say, okay, there's an active inflammation going on in this bowel segment. So let's come to the next one of the fields which PET MR might be highly beneficial for, this multiparametric imaging. So using one examination, one PET MR exam, you can provide functional imaging with the MR components, morphological imaging, and you would also get metabolic information. That might be used by quantifying those data for treatment planning as well as for therapy response assessment. And so you can obtain all those data which have a complementary content, and then you can perform, for example, radiochemotherapy, and you will perform follow-up examination. You will show, are there any differences under therapy, changes of these parameters which can be quantified to evaluate as a responder or non-responder. And so with one examination, we can obtain data for tumor morphology. We can determine the tumor extent. We can indicate the metabolic activity of a primary tumor, as well as we can get information of the microstructure based on the ADC value, as well as about the tumor perfusion or vascularization. So many different parameters which can be used for more complex evaluation of tumors. And so Dr. Pinker from Vienna, she could also show by using multiparametric PET MR-derived functional parameters, she could enable a more significantly better evaluation and differentiation between benign and malignant breast tumors, which might potentially reduce the number of unnecessary breast biopsies. So we also perform studies on primary breast cancer patients, and we use it also for therapy monitoring. So this is a patient with a breast cancer, enhancing breast cancer here in the upper outer quadrant of the left breast, which also shows a focal tracer uptake. And under neoadjuvant chemotherapy, It's significantly decreasing in size, and also the metabolic activity also decreases significantly. So we have more parameters to determine therapy response. And in addition, you can also perform whole body imaging. So in this case, we could also identify that the patient has lymph node metastasis in his left axillary region. And so also we have a local tumor staging tool and a whole body staging tool might also be the potential for one-stop imaging. So now I would like to come to the last point, and that's the potential of PET-MR to reduce the radiation exposure for the patient. And that's basically based on the omission of the CT component. We bring in MR, and that might be highly beneficial for the evaluation of pediatric patients, as well as for those patients which might undergo frequent and repetitive examination, follow-up examination, for example. And so one study which was published last year from colleagues from Tübingen, they could show that PET-MR and PET-CT have an equivalent staging performance on pediatric patients. But which was a big deal that they could show, they could calculate and estimate the radiation exposure, and they could show that using PET-MRI reduced the radiation exposure in comparison to PET-CT of about 73%. That might also be beneficial for patients with lymphomas, since PET-CT is recommended for initial staging, for therapy response assessment, as well as for surveillance of these patients. And lymphoma patients, especially Hodgkin disease patients, they represent a study population or a patient cohort which is younger than normal patients. We sometimes have patients that are 15 or 16 or 17 years old, which we examine. And so initial studies could already show that PET-MR or the initial studies by Platzek from Dresden, they could show, as well as Hickok, that PET-MR performs quite well, but especially only for initial staging and therapy response assessment. I think for follow-up examination we need more time, since we have that scanner only for about 4 years now. But there's one main drawback of PET-MR imaging, and that's the time. So we have the MR component, and it takes much, much longer than a CT scan or a PET-CT scan. So the patient would definitely suffer from a discomfort within the scanner. It was about 45 or 60 minutes for a whole body PET-MR scan. That means we thought and introduced or implemented a fast protocol which we use for PET-MR imaging, we skipped out 6 of the 9 sequences which we're using. And so for whole body imaging we use only a T2 weighted haste sequence, diffusion weighted imaging, and a post-contrast T1 weighted wipe. And by doing so, we could reduce the radiation or the scan duration from a standard PET-MR protocol from 44 minutes to 26 minutes. And that's a lot. That's almost 20 minutes scan duration reduction. And so this is an example, imaging example from one of those patients. She underwent a PET-CT and subsequently a fast PET-MR scan. And you can see there's a tumor lesion in the right hemipelvis, which can be clearly identified with the equivalent accuracy in PET-CT and PET-MRI. And so the PET-CT lasts about 80 minutes, and the fast PET-MRI only 8.5 minutes longer. That's totally acceptable. But which we also could calculate the scan or the radiation exposure for the patient, and we were able to show that using fast PET-MRI enabled a reduction of the radiation dose for the patient from 19.4 millisievert to 4.5 millisievert, and that's a lot. So at the end, let me sum up. So those integrated PET-MR scanners might represent a valuable next generation for hybrid imaging. With integrated PET-MR, we can perform simultaneous PET-MR imaging with these benefits which I've shown. The MR component especially provides a higher soft tissue contrast, as well as different specific MR sequences, including functional imaging. We can obtain or reduce the radiation exposure in comparison to a PET-CT scan, which is definitely beneficial for pediatric patients and also patients with many follow-up examinations. But there are still minor limitations based on the MR-based attenuation correction. And so when we focus on our scanner and our experience, the biograph MMR which we are using is robust, it is a stable hybrid imaging system, and certain other studies could also show that the PET MMR system perform essentially like a standalone PET or MR scanner. And therefore it might have certain applications, wide applications in scientific trials as well as in clinical routine in the future. So thank you very much for your attention.
Thank you very much, Johannes, for your presentation and your using the time firmly. Thank you. Soru veya katkısı olan var mı? Türkçe'de olabilir, İngilizce'de olabilir. Soru veya katkı yoksa ben sorayım o zaman. So, Johannes, I have a question, a brief question. Why we are using particularly 3 Tesla for combining PET and MR?
Why we're using a 3 Tesla scanner?
Yeah, higher field.
I think it's the newest. So I think still 1.5 Tesla is the clinical standard, but now we have 3 Tesla, which have been shown to be highly beneficial for MR imaging, and so it's the newest generation. And so Siemens decided, in that case, to use that 3 Tesla scanner. So I think you have to need the newest PET scanner, and they figured out, they performed a study and looked if there might be any disturbances based on the PET detectors of the MR magnetic field, and they could show that with that new generation, which has been shown priorly, we use the avalanche photodiode PET detectors within the MR scanner. There are not so main disturbances of the magnetic field. So 3 Tesla scanning with using PET MRI is definitely feasible. So,
but most of the patients in your center and gembology centers are the oncologic patients. Don't you think the 1.5 Tesla can be fine to combine PET and MR?
It could definitely be. You could also
the
combine
abdomen patients. Maybe you are right for the neuro patients, but why we are using 3 Tesla for the oncologic patients?
So on the one hand, you might enable get a higher spatial resolution, especially for example, cardiac imaging, or what I've shown, evaluation of the femur pelvis. So with 3 Tesla, you might increase the spatial resolution, which are definitely improvements of the image quality. And so that might be probably one of the goals from increasing the magnetic field strength as well.
Okay, thank you. Başka soru veya katkısı olan? Buyurun.
The correlation of PET MRI images, are there in data for the sensitivity and specificity of the images?
So you mean that we perform whole body
Diffusion,
MR,
virtual
diffusion
PET
imaging?
images?
Diffusion PET?
No, I would like to ask that in Biograph, you also make diffusion examinations,
Yeah,
right?
sure.
Yeah. So you have also the PET MRI imagings. So are there any data that correlate the diagnostic efficacy of the images? Yes.
So I think one of the main goals in PET MR imaging is to reduce the scan duration. And so we also published a study last year which evaluated, or which focused on the additional value of diffusion-weighted imaging in whole-body staging procedures. And we could show that diffusion-weighted imaging, sure, it increases the sensitivity of MRI, but we could show that including diffusion-weighted imaging and excluding diffusion-weighted imaging didn't make such a big difference. So PET is highly sensitive. It's extremely sensitive. And so in this study, which we published in JNM, we could show that in a certain whole body staging trial, diffusion-weighted imaging PET MR didn't enable such a high benefit from diffusion-weighted imaging, since PET is highly sensitive. Yeah. we could skip out it from the protocol. And I think for one body position, diffusion-weighted imaging would need about 2 minutes and 40 seconds. So it's a long time, and we could also reduce the scan duration only with the skip-out diffusion-weighted imaging about 10 minutes. Yeah.
Okay, thank you. Thank you very much.